Lovely people, on this momentous Thursday, the Arab and North African sphere is representing. Literally every
Mhm.
single member who you're about to hear today, odds are can speak very good Arabic, except me. And that includes our guest presenter, who we met for the first time, and I will say hi to. But I have the honor of discussing with our beloved Ibrahim today, who can definitely speak Arabic. I've heard him. Um, and I don't think he really needs an introduction, but I will tell you that it's unreal for me to reflect on the fact that I've known Ibrahim for 2 years now, and he is yet to graduate medical school. Not because he's very far behind, but because he's so incredibly talented and smart that he joined CP Solvers in his very in the youth years of his medical school life, and has really arisen to be a pillar of CP Solvers, as evidenced by the fact that he is one of a very few number of leaders in the VMR space. And if you know Ibrahim and you know leadership, he doesn't mess around. He's kind, gentle, humble, but he makes stuff happen. And I find it fitting to discuss with him today because it's actually his last day rotating with our beloved Dr. Ravi at Sinai Baltimore. And coincidentally, I had a nice conversation with Ravi yesterday, who was beaming about Ibrahim and what he has done physically in his institution. So I'm thrilled to be able to put the cherry on top of the cake of your rotation there and make it a full CP Solvers experience by discussing with you today, Ibrahim. Very, very excited. I'll hand the mic to you to say hello, and then I'll steal it back to give a warm welcome to other people here.
Thanks, Rabih, for the kind introduction. Yeah, just like Rabih mentioned, my name is Ibrahim. I come originally from Sudan, but I grew up with my mom in Saudi. I go to med school there as well. I'm currently in Baltimore for a rotation here. We'll be moving to another state soon for another one. I just wanted to say, Rabih has said a lot of interesting stuff about me, but I think a lot of you have not interacted with Robbie behind the screen, and I feel like everyone can teach medicine, everyone can read books and can basically, gather up information to teach them to their students or to their trainees. But it can be challenging to find someone who is also very much compassionate and shows empathy towards their learners while also teaching them the fundamentals of medicine. And I look up to Robbie just because he embodies both of these traits that I think are very difficult to find in human beings nowadays. So thank you, Robbie.
That's not how it's supposed to work, my friend. I was supposed to make you blush, not the other way around. But I appreciate that. I appreciate the compliment, and I will any wisdom that comes from way is down to the nutritious breakfast that I have. I encourage you all to eat it. Today is no acai. It's just a warm bowl of oats. But speaking of warmth, I think we're gonna keep our Arab very warm, both physically and personality-wise theme going, and actually go over to the UAE to ask Masa to say hi and tell us a little bit about herself and what's new in her life.
Hey everyone, I'm Masa. I'm Syrian, but I'm based in the UAE. Nothing new is going on. I agree with everything that Ibrahim said, and I'm very excited to see him co-discuss Ibrahim. It's such a pleasure to watch you. I think you're very eloquent when you teach, and I'm so excited to share the space with Sosana. It's been a while, so yeah, I'm happy we get to do that today.
Yeah, y'all are tag teaming. Let's go over to Jordan and say hi to Salsa. I feel like I'm like a radio announcer or something popping on across the world. Hi, Salsa.
Hi, Dr. Rabi. Hi, everyone. I'm Sosan. I'm from Jordan, but today I'm not in Jordan. I'm actually in Saudi Arabia.
Oh,
I'm
wow.
visiting my family. Yeah, and I'm excited for Ibrahim's discussion and Bahat's case. And yeah, that's it.
Where in Saudi Arabia are you?
In Khobar,
I
it's
don't know
like
what it is.
in the eastern province.
Eastern part. Wow, wonderful,
Yeah,
amazing. Well, thank you for so much for joining us while you're hanging out with family. And yes, we
my
have Bahat here. Hi, Bahat. Nice to meet you. Tell us a little bit about yourself.
Nice to meet you too. Well, my name is Bahauddin. Um, I actually studied medicine in Ukraine. Just to answer Johan, I didn't study here, but I am Moroccan. Um, what else do I say? I enjoy debate,
Hmm.
swimming. I like swimming a lot,
Yeah.
and I guess clinical reasoning, which is why I'm here.
Wonderful.
So
That's so
yeah.
cool. How did you find yourself in Ukraine? What was that journey like?
Actually,
Hmm.
my cousin went there before me, and then yeah, he told me to actually go there, and yeah, I took the opportunity.
And what was that experience like?
Amazing. It was amazing.
Yeah.
Yeah. Because I kind of like lived with a social bubble with my parents. But then
Yeah.
when I left, I was like, yeah, I had to figure out stuff on my own. So I
Yeah,
kind of,
for
yeah,
sure. And when
yeah.
did you graduate medical school? How long has it been?
Last year.
Last year. Oh
Yeah.
my gosh. So I can only make an educated guess as to what the circumstances in Ukraine were when you were
Yeah,
studying.
it's okay. They were challenging, to say
Yeah,
the least. Yeah.
incredible. And so now you're back in Morocco, huh?
Yes, now I'm back in Morocco. I'm following the PLAB pathway. I actually just passed my PLAB one. And yeah, I want to
Incredible.
finish yeah.
And what would be a dream come true for you from a medicine perspective? Where would you want to be? What would you want to do?
I want to do internal medicine. I just love it. And I would love to be in somewhere like Wales or like, I know it sounds funny because like the weather, people complain, but I love cold weather. I know there's just something weird about me. Yeah.
Oh my gosh.
Anywhere that's cold, sign
Don't
me
say
up.
that too
I'm
loud. My
there.
wife is very close and she hates cold weather. She'll probably start to feel cold even, even when
Already a good start, Bah. Good job.
Okay, I would love everyone to participate in this challenge. Does anybody else like cold weather?
Yes,
Oh wow.
sometime. Yeah.
You got the lady in the warmest country in the world right now, probably wanting cold weather. But
I
thankfully,
believe her. I believe her. Johan did this. He was like, nah, I
yeah,
don't like
Johan,
cold
he
weather.
was giving you some love earlier, but not anymore.
Yeah,
Um,
now he's like, oh, I'm not sure about that.
well, it's incredible. And Deborah. Oh my God, no, you have a fan club. They're just slow because they're
Oh,
probably
really?
too warm to respond. They need it more and more cold. Yeah. Well, Maha, I'd love to ask you, how did you get involved with CP solvers? How did you know about this?
Actually, back in med school, I
Hmm.
think earlier on, I used to come and actually watch somebody
Yeah.
present a case. But yeah,
That's
so
incredible.
I think oh, it was Strong Medicine, Eric Strong, because he
Yes.
did a playlist of how to read what was it? Was it the ECG playlist? And then he recommended you guys. So that's how.
Wow.
So it
That's
was Eric
incredible.
Strong. Yeah.
I'm so glad our paths have crossed. I'm very, very excited to jump in today for your case and hopefully get to know you better and better over the years. And maybe from your journey to Morocco and Wales, we'll hear all about it periodically as you go about it.
Definitely, definitely.
Wonderful. All righty, Masa, we're ready to rock and roll. So feel free to share the screen and Bahat, you take it away. We're ready for you.
All right. So today I'm gonna present a case. So we have a 62-year-old male who complains of fatigue despite enough sleep. Um, he also has some weight loss, complains of weight loss, and daytime somnolence. Now I will stop there.
Fascinating. All righty, Ibrahim, you're deep in the clinical world. I'm curious, what thoughts crossed your mind?
Yeah, honestly, when I first heard fatigue as well as weight loss, I thought both of these are non-specific symptoms and can be attributed to almost anything in medicine if it's severe enough. But I guess just because we have those two symptoms, I'm trying to latch onto a symptom that would be better off to start with. And I think the fatigue would probably be the best choice in this case. Just because weight loss, I feel, is more non-specific even than fatigue. And so when it comes to fatigue, I'm trying to understand first while approaching this problem is this true fatigue or are we talking about weakness? I know that in CP solvers, I was taught that when you approach weakness, you try to rule out neurological causes first. And you basically rule out neurological causes first by establishing if the muscle strength is normal or decreased in such patients. And so if it's decreased muscle strength, you try to localize it by whether or not this is an upper motor neuron disease, a lower motor neuron disease. And then if you're able to establish that it's an upper motor neuron disease based on the location of the decreased muscle strength, you can learn which area of the CNS is involved. Um, and then, however, if there isn't decreased muscle strength and it's mostly profound weakness throughout someone's entire body, I also know that CPS has taught me that there are mimickers of weakness. And the first one that is important to rule out is basically pain, because when someone has this increased pain due to whatever problem is happening in their body, um, due to the pain itself, it overshadows the whole body's response and can result in this profound feeling of weakness. And then if you're able to rule out pain, then this is basically you reach out to the area of asthenia, which I know that we've discussed on a recent rapid VMR. And when it comes to asthenia, you try to basically look into accompanying symptoms. Those accompanying symptoms can help you localize a specific disease. If you're not able to find an accompanying symptoms that can help you reach a diagnosis, then you can ask yourself the question, is the fatigue happening at rest, or is it happening only when someone exerts themselves? And if it's happening at exertion, you know that this is most likely something that has to do with the cardiopulmonary system. If otherwise, then there is a whole list of other differentials that can cause asthenia at rest, I guess. Back to you, Ravi.
Oh my gosh, this is absolutely amazing. I have nothing to add to that reflection. And for all of you who are in a position to teach, I think you can all be tempted to be like, oh, okay, great job, Ibrahim, full stop. But I think good teaching comes at trying to find the knowledge edges of your learner's knowledge. So let's find the edge, Ibrahim, and I'll ask you um, to predict the future. Based on what you just said now, I want to tap into your reflex response, not the slow thinking, but the rapid reflex. So rapid reflex, neuro exam, you think it's going to be weakness or no weakness on neuro exam? What's your reflex? What do you think based on the history? What's your prediction?
Just because I feel like this patient's presentation is more of a chronic one.
Yeah.
So I don't think we would have a neurological deficit in this patient per
So
se.
your reflex is normal strength, which I agree with. That's also my reflex. Do you think this patient will have any cardiovascular abnormalities on exam?
With the weight loss, I'm not sure if I would specifically see any cardiopulmonary involvement here.
Yeah. Superb. So as you start to imagine this patient and what he may look like on exam, you're imagining a patient who has a good, strong heart and good, strong muscles, right? And that tells you a lot about where you think the problem might be. Because you're saying fatigue could be because he can't walk, but you think his heart's great. Fatigue could be because he can't move his muscles, but you think his muscles are great. And so it's really powerful to see how that one line of how he is telling his story can help you predict the exam. And what you're hearing is telling you that this is a diffuse process affecting his whole body. It's making him sleepy, tired, and he's losing weight. The probability of this being a focal problem from one specific part of the body is diminished when somebody has such predominant systemic sleepiness, fatigue, tiredness. And so it's going to be very easy to assume that this is a diffuse systemic process like kidney dysfunction causing uremia. But I think the thing that can happen when somebody is so fatigued is the fatigue can literally be a very thick, large blanket, especially for those of you who like the cold, that can cover and camouflage any evidence of focality. So say, hypothetically, Ibrahim, he has esophageal cancer. And normally he would have prominent dysphagia. But now he's too tired, too fatigued, and is not eating. And so he doesn't have much dysphagia anymore. So what am I doing now, Ibrahim? I am now trying to see if there is evidence of what part of the body this disease lives in to help me figure out why it's launching such a widespread attack on the rest of the body. And it may be that the disease lives in the blood, like kidney dysfunction and subsequent uremia, or it may be that there's focality somewhere, like a large esophageal mass, causing perineoplastic fatigue. And so I think what we really have to listen to is to see, are there any focal symptoms here? And are there any focal findings on exam and labs? So very, very intriguing start. Why don't you give us the next aliquot?
Yeah, just before I say that, Ibrahim, that was very insightful. So I just want to say that you're spot on something already. So but we'll reach that stage. Anyways, so some HPI. So he presented to the hospital with a 2-week history of pruritus, especially at night. And also he had noticed that his stool looks paler recently. And he complained of some abdominal pain. And that is it for this HPI.
Very, very. I love this sneaky presentation. Just the HPI. I love it. All right, Ibrahim. What did Bahat do now? Where are we going?
Yeah, so honestly, when I heard the word pruritus, I felt like we were approaching the world of derm. But I also know that, you know, once a dermatologist uh, at my school back home taught me that not all pruritus is specifically dermatological stuff. And sometimes it can actually pinpoint towards a systemic process that is happening in someone that is causing or resulting in that pruritus. And I say this because I had once seen a patient with Hodgkin's lymphoma who had this initial presentation of pruritus, and basically we had to run around figuring out why this patient had pruritus until the masterful clinician weighed in and said, like, you know, why haven't you thought about Hodgkin's lymphoma? And the patient ended up actually having Hodgkin's lymphoma. That being said, I feel like a lot of patients in an actual hospital setting can have pruritus due to multiple reasons, and because these patients often present with multiple issues at once. So not to anchor on that at the moment. I think what's really interesting in this article as well is that this patient had pale stools. And when I think of pale stools, my system one thinking makes me think about an issue with the bile drainage itself. And so whatever is causing the bile not to flow into the GI system can cause pale stool. And with abdominal pain, I worry that there is a process happening in the abdomen causing that bile to actually obstruct from being drained into the bowel itself. And so something like a malignancy could definitely result in that. But once again, I feel like it's way, way too early without at least preliminary testing and physical exam to anchor on that theory. I'd probably, for the abdominal pain, I'd probably try to draw a temporal relationship for this abdominal pain in relation to the patient's other symptoms. But so far, I feel like B symptoms here overshadow everything else. But would love to hear your thoughts, Bobby.
Yeah, I'm right there with you. I think, Ibrahim, the combination of pruritus, pale stool, and abdominal pain is very suggestive of the focus of asymmetry being in the liver. And I just wanted to arm you all with the idea that whenever somebody with liver disease comes and is confused and sleepy and tired and has daytime somnolence, you really have to worry about how bad this liver disease is. Most people who have cholestatic liver disease are not sleepy and somnolent in the daytime. And so for me, the severity of the syndrome is now raising concern for the two forms of liver disease that are associated with brain dysfunction, acute liver failure and decompensated cirrhosis. So the next steps that I would be doing on exam is to see, does this patient have evidence of cirrhosis or not, which would really raise the concern. So we're having two things that now merge together that raise a spectrum of really alarming possibilities. There are other causes of altered mental status and biliary disease such as cholangitis, but that is usually a little bit more acute and a little bit more hectic. So I just want to put a pin in that even though this patient's had 2 weeks of symptoms, the combination of these two things raises concern for something more fulminant and may rapidly progress before our eyes. All right, Baha, you have us very intrigued. Go ahead, Imran.
Yes, Robbie, I just had a question before we move on to the next alipod. Just when it comes to the theory of liver being involved here, I was wondering, how do you think about the abdominal pain in this patient as well?
Yeah, I think this was a topic that we had the chance to reflect on. Whenever the liver is painful, the odds are that it is blocked, and it can be blocked at the biliary tree. It can be blocked at the hepatic vein, or there can be primary stretch of the liver capsule from a large mass. And so, of course, the abdominal pain may be separate from the liver, but if you're trying to picture what's happening to the liver, picture the capsule being stretched by biliary, venous, or biliary or venous outflow obstruction, or a infiltrative disease or a mass-forming disease stretching the liver capsule. Really, really good question. All right, what do you have next for us? We're very intrigued.
So just before we wrap up the first aliquot, I'm gonna add that his wife said that he often complains of bloating, especially after he eats fatty food. So do you guys want to have a comment on this, or?
I think for the sake of time, Bahat, we're 25 minutes in, so why don't we
All right.
maybe go to aliquot?
So we can move on to the second aliquot. So past medical history, he has a history of chronic gastritis type B. He also has atopic asthma and constipation. Now, for social history, he is retired. There's no history of smoking or drinking, no recent travel, no allergies, and he taking any current medication. And also, I want to highlight that this patient doesn't take any herbal supplements. And that will be it for this aliquot.
Wonderful. Ibrahim, I imagine that the case will get a lot of momentum when we do the exam and labs. So maybe you can just share your reflex thoughts here in a minute, and then we can move on to the heavier part of the case.
Yeah, honestly, whatever I'm seeing in this patient is something that doesn't freak me out, at least until now.
Yeah.
So the history of atopic asthma, the constipation, those are things that are commonly seen. The fact that he doesn't have a family history of malignancy, medications, I'm not seeing anything here that would reflexively make me think of whatever is causing their symptoms. As well as the history, I'm not sure if this patient is based in the Middle East, but we've had a lot of Middle East cases with TB. But without the history of recent travel, I think that makes me less suspicious of the Trinitology. So yeah, I think we're definitely ready to hear the next aliquot if you are, Robbie, as well.
Yeah,
Yeah,
sure.
I agree with you. Why don't you tell us? Go ahead.
I think, yeah, so temperature, he was afebrile, heart rate was 72, BP was 120/80, respiratory rate was 18, and his saturation was 96. Now, all of the systems were actually normal. Just to answer the neurological exam, there was no deficit. There was some muscle wasting, but also the abdominal exam, he had tenderness over the right upper quadrant and the left upper quadrant.
Fascinating. Excellent exam. I thank you for focusing on just the pertinent parts. Wow, that was really, really helpful. So Ibrahim, what do you make of this exam? Where did it take you?
Yeah, at this point, honestly, hearing the patient had a normal neurological exam, at least makes me think that this patient would probably now fit the definition of asthenia, just because there are no deficits and just because they're not in pain, at least as far as I'm hearing at the moment. The tenderness in the right upper quadrant and the left upper quadrant, while we did suspect that based on the HPI, I think is reassuring and would make me push forward for some type of imaging for this patient just because I think there's an underlying process happening here. I think the next question would be, what type of underlying process are we looking into? And just because this patient also has tenderness in the left upper quadrant, does not I don't think that it makes me less worried about the liver being involved. Uh, just because it can be very much involved to the point that the inflammation is reaching the left upper side, which is once again causing the left upper quadrant. The muscle wasting, I think with the fatigue and the weight loss and the other B symptoms that we are seeing in this patient, as well as their age, I don't think that is something that um, would be a huge red flag for me for the time being that I wouldn't have suspected otherwise. But would love to hear your thoughts as well, Robbie.
Yeah, absolutely outstanding. I'm right there with you. I think the muscle wasting helps us time the syndrome to be a little bit more long-standing than 2 weeks. And I think it's very, very telling to say, okay, this has been going on likely for 2 weeks. Uh, and we have more momentum that this is a liver process that's been going on for 2 weeks. But we also know it probably hasn't been going on for 2 or 3 years because the patient doesn't appear to have the stigmata of cirrhosis. Namely, he doesn't have ascites or caput medusa or palmate erythema. And so I think you can localize the timing of the syndrome to be more than 2 weeks based on the muscle weakness, but not too long based on the absence of cirrhosis. And I think those are very, very intriguing. And I think what is also intriguing is the disconnect between the pruritus, the fact that he's itchy, but does not appear to be jaundiced. And I will tell you that it's actually a little bit difficult to be confident about jaundice on exam. I have missed jaundice many a time. And so I think that what I'm now intrigued to try to figure out is, what is the nature of this liver disease? How come it's chronic enough to cause muscle wasting, but not chronic enough to cause cirrhosis? And I'm really interested in that disconnect. Just as I am interested in the disconnect between the pruritus and the lack of jaundice, which may be on account of the difficulty of detecting jaundice, but the labs will tell us if that's true or not. And then the other element that you mentioned is the left upper quadrant pain. And so I think the open questions are, what is the time course of this disease? What's the deal between the disconnect between the itching and the billy? And what is this left upper quadrant pain about? And I think the labs will help us answer those questions. But I have to tell you, Baha, I don't think you have any reason to be nervous, quite honestly. This is such an outstanding, cool, calm, collected case presentation. So I love it. I'll hand the mic to you to take us to the next aliquot.
Now, you just touched on something that I wanted to actually point towards. Before I say the labs, this patient, where he was treated and where he resides are actually too far cities. So before we ordered the labs and the imaging, he actually went back home and he had to travel somewhere and he didn't want to be treated. Now, the next time he came in, he actually had icterus. And so that's just to answer your question. He was jaundiced the second time he came in. Now, for the lab results, his white blood cells were 3,140. That's low. His platelets were very low, so not very low, but yeah, 115. His coagulation panel was good. His bilirubin was slightly elevated, 1.9. His cholesterol was also high. Do I say the LFTs now, or do you guys need to discuss this?
Oh, please, we're so hungry for
Okay.
these.
Okay. So as for the LFTs, the ALT was normal, the AST was 59, that is high. The ALP was 210, that is high. and the GGT was 442. That's also high. His albumin was normal. Now, that is it, before I can tell you the ultrasound finding.
Absolutely amazing. Ibrahim, I'm going to do something that we haven't done in a while because of how intriguing this case is. I'm actually going to do some breakout rooms because I think that it'd be a really, really good idea for people to try to get as much juice as they can from the labs. I will tell you that you're very lucky, Ibrahim, because you're hanging out with Deborah, Mark, and Mengu. So enjoy it. You're going to be much the wiser. So for those of you who may not have been part of it, I would love for you all if you're able to join a breakout room and just chat with a smaller group to get your thoughts out there. And Ibrahim will benefit from three brilliant minds, and so I hope you you get to do so too. And we'll all come back in the next maybe 3 or 4 minutes. Okay?
So Rabih, I just had a question, sorry,
Yeah.
for Baha before we move on. So Baha, do you
Yeah,
know
sure.
if the bilirubin was mostly indirect or was it direct?
Yeah, it was mostly indirect.
Okay. Thank you for clarifying.
It's okay.
All right, guys, enjoy your breakout rooms. Bahat, you can also join if you want.
I'm not sure what I'm supposed. Oh, I can.
Yeah,
Okay,
join.
sure.
Don't tell
Okay.
anybody anything. Don't tell
Okay.
people the answer, but you can hang out with them and just, learn.
Sure. Okay.
Ravi, we cannot hear you.
Oh no, I was muted.
Yes.
Oh no. Guys, I was telling people about the case review committee, and Deborah told me that I was muted while you were all gone. So let me tell them one more time. Guys, please, please, please present your cases. All you have to do is go here to, I'm going to share my screen in a second, is go to clinicalproblemsolving.com, morning report right here. This is what Baha did, and present a case. We want all of you to do it, every single one. If you are watching a YouTube video and you have not presented a case, you got to present a case. It's really the lifeline of this community, and we'd love to hear all the UTIs, the pneumonias, the HLHs, every single one of them. But anyway, since I botched that abysmally, thank you, Deborah. Ibrahim, what was it like with the wisdom of the CP Solvers team with you? What did you come up with?
Yeah, I think
Sorry, I want to
think
clarify something, Ibrahim. The bilirubin was direct. I think I had told you indirect. And also he was hepatitis negative. I had to add that. So you guys don't think infectious.
got it. Okay, so honestly, Mark has shared so much wisdom with me in the breakout room. And so I guess we were trying just to fit in the patient's diagnostics with their history. And I didn't know about this pearl before, but Mark has shared with me that it would be a bit unusual for this patient to have pruritus given their level of hyperbilirubinemia. And so even if a patient does have hyperbilirubinemia, you don't typically expect pruritus to happen when it's less than 2.5. And so we were discussing the possibility of this patient having something like intermittent a blockage within their system. Another possibility as well could be that this patient reported history of pruritus beforehand, but now they don't have pruritus given their level of bilirubin. And so I thought that was interesting. That would be interesting to clarify from Baha as well. Um, Otherwise, I think also how I would approach this patient for next steps would typically be with further diagnostics, but specifically imaging, just because I'm very much worried about a malignancy happening in this patient. And I've been taught this by Yusuf, the R factor. I know that the R factor was actually made up for drug liver injury, but I think it's there has been studies that has demonstrated its power in areas elsewhere. And so when you look at the R factor for this patient, given their level of ALT and LP, it pinpoints more towards a cholestatic injury. That being said, I wouldn't just rule out. So I think in every patient who presents like this, even though if you have the R factor pointing towards a cholestatic injury, I don't think it would be wise to just say, oh, we're not gonna like pursue diagnostics for liver injury and hepatitis panel, etc. But that helps in establishing at least first steps when it comes to choosing a right upper quadrant ultrasound and maybe then going or proceeding forth with a CT abdomen. But these were my thoughts, but would love to hear your thoughts as well.
Yeah, absolutely outstanding thoughts. I'm right there with you, Arun. And I think that if we just first take the step of simplifying this whole case and say, if we explain the labs, will we explain everything? And I think the answer is yes. And so I agree with you that you're coming to the conclusion that this person has primary cholestatic liver disease, which is basically saying that this disease does not live in the liver cells, it lives in the bile ducts. And you have to recognize that if you are thinking of a bile duct disease, the bile ducts begin the moment you enter the duodenum and go into the ampulla. And if you're imagining them and you're on the inside of them, you're going up the common bile duct and you could have a disease there. Then you go into the hepatic ducts. And then all of a sudden, the ducts become really, really small and they start to be microscopic biliary disease. And so the way we break down primary cholestatic disease is to say, is it in the macroscopic big ducts that a radiologist can see? Or is it in the microscopic ducts that are in the liver themselves? And the best way of trying to figure out where the disease is to get imaging, ideally a CT, but sometimes an ultrasound, to see, oh, are the ducts that are large diseased or are they not? And if they're not diseased, we then assume that it's in the microscopic ducts in the liver. But all tests, including imaging, have to be formed with a pre-test probability. So Ibrahim, as we're investigating this cholestatic liver disease, we have to ask ourselves, what is the pre-test probability of extrahepatic biliary disease? And I will say that I'm worried about an intrahepatic disease primarily, which is I expect the imaging to not be entirely explanatory. Now, why is that? The reason for that is most of the time, patients who have extrahepatic biliary disease are not confused. Most of the time, when there is intrahepatic biliary disease, the patient gets altered and the AST goes up, reflecting disease spilling over into the adjacent hepatocytes. And most importantly, if you are trying to connect a systemic disease, namely pancytopenia, to the liver, it's much more likely that you are able to connect them in the intrahepatic portion rather than the extrahepatic portion. The extrahepatic portion of the liver is usually diseases that actually are either local, like stones or biliary parasites or strictures, or metastatic solid tumors like pancreatic or cholangiocarcinoma, which usually don't result in pancytopenia. So I would say that we should approach trying to localize this biliary disease with a hypothesis in mind, intra versus extrahepatic. The fact that the patient's brain is down, heme is down, and AST is up are all signs that suggest that the location of this disease is in the liver itself rather than the extrahepatic tree. But imaging will help us make a lot of progress. So Baha, why don't you give us that next outline?
Sure. That was amazing, by the way. So the ultrasound findings, he had hepatomegaly, he had irregular liver contours with increased echogenicity, and all the ducts were actually not dilated. There were also no stones in the gallbladder, and also an autoimmune panel was ordered. Do I say it now?
Yeah, go for it, please.
Yeah, so the ANA antibodies were negative, the liver and kidney microsome antibodies were negative, the smooth muscle antibodies were negative, and the AMA antibodies were positive.
Excellent.
And that is it.
Sure. All right, Ibrahim, what do you think?
So honestly, when in the breakout room, we also so basically I'm just looking at the problem here. So starting from the ultrasound, I guess. So the hepatomegaly, the irregular liver contours, all of that makes me think about cirrhosis progressing in this patient, as well as the increased echogenicity. That being said, I agree with Baha with the autoimmune panel, and I think one of the things that we have discussed in the breakout room with Mark is if there is an underlying sinister process, an autoimmune disease like IgG4 disease that is causing something with an intermittent nature, resulting in the intermittent pruritus and the not so elevated bilirubin at the moment. But then I'm not sure what to make of the AMA antibodies. Are those the anti-muscular antibodies,
Yes.
Baha? Or
Yeah,
okay,
they are.
okay.
Maybe I
So
can just
just
to clarify. Sorry, not to interrupt you. I'm under the impression, and Baha, please correct me if I'm wrong, that AMA stands for anti-mitochondrial antibody. Is that right?
Yeah, sure. Yeah, sorry. Yeah. The anti-mitochondrial antibody.
See, I read your mind
Yeah.
all the way across an ocean.
yeah, thank you for clarifying, Rabih,
Yeah.
because I was definitely thrown out by the anti-muscular antibodies. But yeah, for the autoimmune panel, the fact that this patient had positive, the way I remember it from step one setting is that anti-mitochondrial antibodies are associated with primary biliary cholangitis as well as autoimmune hepatitis. But I do know that there are multiple types of autoimmune hepatitis, and you basically um, need to find specific antibodies for each type of these. So this is where I'm currently latching on at the moment, the theory of PBC as well as autoimmune hepatitis. The fact that this patient did not have any dilated ducts on ultrasound imaging makes me think less of PBC and more of autoimmune hepatitis. But sometimes just because ultrasound can be dependent on the provider themselves, I'd probably pursue further imaging for this patient prior to getting into before latching onto that specific diagnosis.
Beautiful. Let me take an opportunity to clarify something for you, Ibrahim, because I think that your analysis is superb. And then there's one thing that I think may not be crystal clear in your mind, but this is a great opportunity to do that because you're saying that you are less likely to diagnose PBC because there is no biliary duct dilation. So let's break that down a little bit. So when you see biliary duct dilation, that tells you that you're dealing with extrahepatic biliary disease, right? So that means that the macroscopic biliary ducts are dysfunctional. Primary biliary cholangitis is a disease of the intrahepatic ducts, the microscopic ones. So actually, it supports your conclusion that the patient does not have biliary ducts because what's happening, Ibrahim, is this microscopic small ducts are all getting fibrosed and compressed by granulomas. feature of PBC on biopsy. So the ducts are not dilated, they're actually compressed, and they're so compressed that they don't work. And so I think the conclusions that you're coming to about being worried about primary biliary cholangitis is very, very wise. I also really appreciate that you called it primary biliary cholangitis, because the former term primary biliary cirrhosis implied that everybody who has it has cirrhosis, and that's not true. But I have an interesting question for you, Ibrahim. How is the pancytopenia fitting in with your hypothesis of primary biliary cholangitis? Well, how are those two merging together?
Oh, so if I had to think about it this way, I'd probably think that there is underproduction from the bone marrow, um, just based off this patient's diagnosis and the inflammation that they have, that their bone marrow is overwhelmed, and this is causing the pancytopenia. But I'm also not sure about this, to be honest.
Yeah. Yeah, I think that whenever patients are kind of systemically ill, the bone marrow isn't happy and can shut down. In general, Ibrahim, if you have a patient who has liver disease, especially a liver disease that is chronic, like PBC, what do you think the most common cause of pancytopenia is in a patient with a chronic liver disease?
Okay. So I know that patients with liver disease can have thrombocytopenia just
Yeah.
because the liver is damaged and is unable to make modulatory molecules that
Yes.
induce the production of platelets.
Correct.
But also, when it comes to the hemolysis and the decreased white count, I think this is why I'm trying to think mostly of the bone marrow
Mm.
rather than a liver specific problem.
Yeah.
But once again, I'm not really sure.
100%. No, this is definitely a place that is. I know you know this, and so I'm going to ask you one more. What do you think about the left upper quadrant pain? What's in the left upper quadrant?
Okay, so could it be congestive and
Yes.
then the spleen is consuming all? Okay.
Click, click, click. See, you knew it. This is the beauty of exposing yourself, Ibrahim. You had this in your mind, and I know you have it because I've interacted with you so many times. And so this is the beauty of seeing cases and solving cases. They make you bring your knowledge to life. And yeah, so whenever you have pancytopenia in the context of liver disease, you worry that the patient has developed portal hypertension and is making the spleen so big that it is consuming the cells. And so here, Ibrahim, you might say, well, wait, Rabih, the patient doesn't have signs of cirrhosis on exam. There's no polymerythema, gynecomastia, and that's where you have to know that primary biliary cholangitis can cause portal hypertension without cirrhosis. It's one of the most common causes of non-cirrhotic portal hypertension. And the pathophysiology of that is the bile ducts are diseased right next to the microscopic portal vein. And so if you're thinking you're in the liver itself and the biliary disease is functional, right next to them is the portal vein, and that gets compressed. So this is a classic presentation for primary biliary cholangitis, which we'll recap in 1 second. But I'd love, Ibrahim, can you point out something that is very unusual about a diagnosis of PBC in this situation? What makes it very weird and unusual? Do you know?
I mean, the fact that this patient seemed to develop their symptoms so fast, worries me about an autoimmune process. And then I'm not sure, to be honest, but the fact that their liver enzymes do not also seem to be so highly elevated, despite the fact that they have a disease that's basically running in the ducts inside of their liver. So basically, the fact that there is an absent gradual destruction and the fact that their LFTs do not seem to fit in the diagnosis very well is what worries me the most in this patient. And also the patient's age. I know that autoimmune diseases can happen in the entire population, regardless of how old they are, but I typically expect this diagnosis in someone who's middle-aged. But would love to hear your thoughts as well, Rabih.
All that is spot on. With one major addition is which gender do you associate more autoimmunity?
Oh, probably women.
Yeah, exactly right. And I think that's the most unusual thing. So if you anchor yourself in the pathophysiology that PBC is a disease of just the bile duct cells, not the liver cells. The liver cells are fine. That's why the AST and ALT are relatively normal. And counterintuitively, it is actually a disease of middle-aged people. So his age is fine for it, even though, as you pointed out, you usually expect autoimmune disease to affect younger people, and that's true, but this is the exception, one of the exceptions to that. What is unusual is diagnosing it in a man. The male to female ratio of PBC is 1/9, meaning that you're 1 out of 10 people with PBC are men. The other 9 are women. So that's why you have to cautiously diagnose this in a patient with PBC and in a patient who's a man. But otherwise, the presentation is classic. And the reason it's classic is actually the disconnect. It's all about remember the questions that we had outlined earlier in the exam? What's the left upper quadrant pain about? Probably splenomegaly. Why is there a disconnect between the muscle atrophy and the lack of cirrhosis? A chronic disease that is progressing towards cirrhosis, has reached that destination radiographically, but has not reached that destination clinically. Why is there a disconnect between the pruritus and the bilirubin? The answer is intrahepatic cholestasis. Whenever you have intrahepatic cholestasis, you have extreme amounts of pruritus. In fact, there's a condition called intrahepatic cholestasis of pregnancy, which is an intrahepatic cholestatic disease where there is no bilirubin elevation. Disproportionate elevation of bile salts and cholesterol, which we have measured here, are a feature of intrahepatic disease and a clue that the localization is intrahepatic. So PBC answers all those questions very, very elegantly. And so, Baha, maybe I can hand you the mic to tell us how you were thinking about it. What happened next? What did you do for the patient?
Yeah, so when we actually reached the part where the anti-mitochondrial antibodies were positive, along with the fitting clinical picture and the fact that his neurological exam was good, we were thinking of that his fatigue wasn't really a central effect. It was more of a peripheral muscular tiredness, because he complained that he wasn't able to like lift his arms and like do very typical, I don't know, drink a cup of tea. So along with that, and the fact that his ALP was 1.5 times higher than the normal, we were thinking of primary biliary cholangitis, which was the final diagnosis. Also, this is an ongoing case, and a fibroscan is ordered just to see the extent of the scarring. It hasn't come back yet, unfortunately, but yeah, those are the final thoughts.
I just absolutely love this case. I think there's so much learning in it, and I really appreciate you bringing it here. I hope we get to see you here more often and learn from your cases, and I hope that you've inspired other people to submit their cases and teach us. This is absolutely awesome. I'd love to get your reflections on what it was like to take care of this patient, and then hear about Ibrahim's experience. So take it away, Baha. What was it like taking care of this?
Honestly, I was with the bilirubin. I honestly didn't grasp the correlation, because I thought like 1.9 and the pruritus, so I was a little bit thrown off. But I think when we had the ultrasound that had mentioned that the intrahepatic ducts were not dilated, we actually started to think of differential diagnosis of is it autoimmune hepatitis, is it primary sclerosing cirrhosis, or is it primary biliary cholangitis? So yeah. And actually, to now, we still don't understand the bilirubin. Why was it very low? I don't. Maybe you guys can discuss that. Yeah.
Yeah, and in most patients with primary biliary cholangitis, the bilirubin is low until they develop cirrhosis, and it really is.
Okay.
It really is a marker. It reminds us that bilirubin clearance is a key part of liver disease. And when there is bilirubin elevated from the liver itself, it usually represents very advanced disease. And so I think that it's pretty common when you're picking it up early, as you did, to have a normal bilirubin. In fact, the classic case of PBC is that the alk phos is high, the GGT is high, the bili is normal, but the patient's very itchy. And the disconnect between the pruritus and the bili is a clue to the intrahepatic nature of the disease. And your clue also, cholesterol and LDL are high as well.
Yes. Yeah. I just wanted to point out that there was a criteria, and that is even though if the anti-mitochondrial antibodies are negative, that doesn't rule out primary biliary cholangitis. But that, if it's positive, alongside the fact that ALP is 1.5 higher than the normal, it actually tends to, and the biopsy, which is invasive, it tends to point you towards PBC.
Oh, beautiful. I feel like you should take my job next time. Okay, so next Thursday you're gonna go facilitate. That was awesome.
Definitely.
Ibrahim, how did it feel for you? What did you learn?
Yeah, honestly, thank you, Baha, for bringing on this case. I love discussing it so much, and I think I'm very intrigued to learn that primary biliary cholangitis has such a predilection for women. That was new
Yeah.
for me. And then just
Yeah.
because I couldn't wait, I guess I was trying to understand why there is this disconnect between the liver function test and the disease that this patient has. I just looked it up because I guess I couldn't wait. And that is actually very much established. So the serum levels of aminotransferases often are rarely increased more than 5-fold than normal. And so this was something very much expected for this patient. I guess I just had a question for Baha as well, just because while I was reading, I came across this fact that this disease, more than 70% of patients with primary biliary cholangitis can also have an underlying disease related to their diagnosis. And so I'm just curious, did this patient end up actually having a disease, or
It's
was it
usually a
just this?
thyroid function. Yeah, they tend to have like hypothyroidism, but in this case, no, there was no concurrent disease. But also, I think I owe you an apology, because the sole reason why I wanted to present this case, because in med school and in literature, they teach us that this is a women's disease. So this was the sole reason why I wanted to present this case, because he's a man and you wouldn't think of that.
Yeah.
So I think that also threw you off, Ibrahim.
Yeah,
You did very well. Thank you. Thank you, Baha.
I think
No, you're welcome.
it's such an important point. I think that risk factors are risk factors, and almost nothing makes you immune to any disease, unfortunately. And so I think you're right. It's much easier to think of this in a woman than it is in a man, and that's because odds are. But that's the beauty of what you do in clinical reasoning, is if you define your problem very well and you say, okay, this is intrahepatic cholestasis. We've proven that the liver ducts are normal. What is the most common cause of chronic, i.e. muscle wasting? Muscle wasting equals chronic. What is the most common cause of chronic intrahepatic cholestatic liver disease? Primary biliary cholangitis, number 1, 2, 3. There is almost nothing else that causes a chronic intrahepatic cholestatic disease. Of course, drugs cause acute disease. Infections like leptospirosis and syphilis can cause acute disease. Cancers can cause acute disease. As an example, IgG4 disease, much more subacute. So if you say, okay, this is a chronic intrahepatic cholestatic disease, this is PBC until proven otherwise, in a man, woman, child, 100-year-old, 3-year-old, Really, really important to just define the problem well. But we get to do another round of learning. Salsa, I'll hand the mic to you to take us home.
Excellent case presentation, Baha. We really learned a lot, and mashallah, Ibrahim, you did amazing. So, starting with the case, we had a 62-year-old male who presents complaining of fatigue and daytime somnolence, weight loss. So he presented with kind of like systemic symptoms and non-specific. And Ibrahim told us to always think of, whenever we hear fatigue, is it fatigue or weakness? And to think of mimickers of weakness. For example, pain can be one of these mimickers. And usually when we have the presentation to be more like predominant of systemic presentation, this makes a diffuse problem more likely and diminishes a focal problem. But we also have to keep in mind that focal problems are progressing into a more like systemic systemic problem. And moving down through the case and getting more information, the patient had pruritus. And Ibrahim also mentioned that pruritus does not always indicate a dermatological problem. We have systemic diseases that can present with pruritus, for example, lymphoma, polycythemia vera, for example. And then with the pale stools that the patient have, the abdominal pain, and the pruritus, we were focusing more on the liver. And we were trying to link the liver problems with causes of altered mental status as well. And things to keep in mind are decompensated cirrhosis or acute liver failure. And then we were talking about pain in the right upper quadrant and the process behind it. And Dr. Rabih mentioned that we have stretching in the liver capsule that is either due to biliary or venous outflow obstruction, or something that is infiltrating, or a mass that is growing and distending the capsule. And then we also talked about how can the physical exam findings help us know about how long has the disease been going on. And the muscle wasting here indicates that this has been brewing for a while, so more of a chronic or long-standing problem. And also Ibrahim shared a thought that he learned from Mark, which was that it is unlikely to have pruritus with a hyperbilirubinemia if the bilirubin was less than 2.5. And we also talked about how the R factor can help us classify the types of liver injury, whether it is cholestatic, hepatocellular, or a mixed pattern. And I feel like one of the highlights of this session is to know whether is this an extrahepatic disease process or an intrahepatic disease process. And Dr. Rabih mentioned that most of the time patients with extrahepatic disease processes are not confused and do not have this altered mentation. And most intrahepatic diseases present with altered mental status and elevated ASTs. And we talked about the association of anti-mitochondrial antibodies with primary biliary cholangitis and autoimmune hepatitis. And another pearl about extra and intrahepatic diseases is that when we see biliary duct dilation, this indicates that we're having an extrahepatic process. And primary biliary cholangitis is considered an intrahepatic bile duct process and disease. That's why we do not see biliary duct dilation. And about the pancytopenia and liver abnormalities, in this case, we could link it to portal hypertension, and that is causing this consumptive process. And here in primary biliary cholangitis, when we have disease in the fibrosed bile ducts, these bile ducts are near to the portal vein, so it can compress it and cause a form of non-cirrhotic hypertension. And another thing, or the last thing that I want to mention is that, which Dr. Rabih just mentioned, is that the most common cause of chronic intrahepatic cholestasis is by far primary biliary cholangitis. And thank you so much.
Oh, it was absolutely outstanding. I'll read to you what Lyra said. The whiteboard is too small for your wisdom, and I couldn't agree more. That was absolutely outstanding. It was a real treat to spend this hour with my Arabic-speaking friends. I have one final question for any of you. How do you say spleen in Arabic? I've always wanted to know. Anybody know?
Should I go, or Ibrahim, do you want to take
you're the
this?
teaching points. How do you say spleen in
Go
Arabic?
ahead, Sausan. You got this.
Spleen in Arabic is tahal.
Hal?
Tahal.
Hal. Amazing.
Tahal,
Do you agree? Is that how you say it in Morocco, or is it different?
Definitely, that was spot on.
Perfect, huh? All right. Do we have Ibrahim and Masa's approval too? Yes, no, maybe. Okay. I sense the answer is yes, or that something's too smart for anybody to disagree with anyway. All right, guys, have a great rest of your day. Bye.
Thank you, everyone. Bye bye.